You're listening to Season 2 of Medscape's In Discussion series on idiopathic pulmonary fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, pulmonologist and professor of medicine in the Center for Interstitial Lung Disease at National Jewish Health in Denver, Colorado. Dr. Swigris specializes in the clinical care of patients with interstitial lung disease and directs research centered on how interstitial lung disease affects how patients feel and function in their daily lives, how to best measure those effects, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Welcome to Season 2 of the Medscape In Discussion podcast series on idiopathic pulmonary fibrosis, or IPF. This is Dr. Jeff Swigris. Today we'll be discussing IPF and palliative care with our guest, Dr. Anna Gersten. Dr. Gersten is Assistant Professor of Medicine and the Director of the Breathlessness Clinic in the Department of Pulmonary and Critical Care Medicine at Johns Hopkins Hospital in Baltimore, Maryland. Welcome to the Medscape In Discussion podcast.
Thank you so much for having me.
Let me ask you, what drew you into the field of palliative medicine?
So I'll say that I've always had a longstanding interest in understanding the patient and care partner perspective and how we tailor medical care to most optimize quality of life, and how we really try to keep our medical care in line with the patient preferences. Throughout my training in internal medicine and then pulmonary and critical care, I really thought about this a lot and learned some tips and tricks, but didn't feel like I had true expertise in really knowing how to do this as well as I wanted to. And that's what actually prompted me to do a formal fellowship in hospice and palliative medicine after I finished my fellowship in pulmonary and critical care. And I really benefited from this particular fellowship because I think I learned to see things in such a different light. And then I learned what hospice care looks like in a variety of different settings, which I hadn't had experience in before. And I think it really helps me when I'm counseling patients and their care partners to be able to more clearly articulate what does this care bundle look like in different types of settings.
You know, lung fibrosis really gets the attention of us as pulmonologists because the general rule for at least many forms of pulmonary fibrosis is progression. And as the disease progresses, we see symptoms worsen. We see that patients need supplemental oxygen, and their health status and quality of life is profoundly impaired, and it only worsens as the disease progresses. And so with your wonderful answer about how you got involved in palliative medicine, define palliative care for us and just remind us what that is.
Sure. So palliative care at its root actually comes from the Latin root of pallium, which literally means to cloak. And I love this because the whole idea here is just this added layer of support, cloaking both the patient and their family, other care partners with extra support. And that's going to look different for everyone. But I would say palliative care is care directed at patients with serious illness that's aimed to help patients and their families navigate the care continuum as their disease evolves in whatever way it will evolve.
I just love that word, cloak, surrounding these patients and their families with supportive care. That is just wonderful. Why are people, patients, and some practitioners afraid of palliative care? It's almost taboo. Patients feel like, oh, I don't want palliative care. That's bad. Why is it perceived that way?
That's a really good question. And I think I'd be remiss if I didn't give a little bit of historical background here. A lot of this entered mainstream media with the idea of death panels. And without giving a whole history lesson, the idea here was that as part of the Affordable Care Act, what they were trying to introduce is the concept that specific visits dedicated to advanced care planning would be reimbursed by Medicare. This was important because to date, providers couldn't actually seek financial compensation for the time spent in this type of conversation. And what happened is that this got a little bit misconstrued to mainstream as the idea of death panels, where the government would somehow make decisions about who's quote unquote worthy of receiving care, and that all of these conversations would automatically equate to end-of-life care death then and there. And so I think in this context, it was very highly publicized in a negative light, which made people nervous. And then the other part to this is that I think palliative care in a lot of people's minds becomes synonymous with hospice care. It's not, they're very different, but I do think that each individual formulates the way that they see palliative care based off of their own prior experiences. And unfortunately, a lot of those experiences can be negative. And so when I'm first introducing myself in a palliative care light, I always kind of start with exploring what has been your experience with palliative care. And oftentimes people will say, my grandmother was on hospice and X, Y, and Z happened. And then I always try to take a step back and say, I'm so sorry that you had that experience. Let's talk a little bit about what the difference is between these two concepts. And I found that can be really helpful in shedding a little bit of light on the heart of palliative care, and then trying to move away from a lot of the misconceptions that people have developed over time.
Yeah. So let's talk about some of the specifics in terms of the role of palliative care that experts like you and others provide to patients with idiopathic pulmonary fibrosis. What does a visit to a palliative care specialist look like for a patient with IPF?
That's a really good question. I am a big proponent of introduction of palliative care at the time of diagnosis for people with IPF. And then what I would say is that over time, the role of palliative care will ebb and flow as their symptoms, as their disease might change in different directions. In terms of what does a palliative care visit look like, what I would say is really the heart of a palliative care visit is to try to understand where a patient and their care partner might be and what is the place where we can potentially intervene to help provide a little bit more comfort, to cloak in support at that time. I will say that in general, palliative care visits usually start with symptom assessment and then management. And in patients with IPF, we know that 80% of them struggle with cough, 60% of them struggle with depression. So those are going to be symptoms that we certainly want to screen for and address if they're present. The other real heart of a palliative care visit for a patient with IPF would be the notion of advanced care planning. And I think it is particularly important in this patient population when we worry a lot that if they were to reach the point of needing mechanical ventilation, the likelihood that we would be able to successfully wean them off is usually unfortunately low. And so I do think that there is a time-sensitive role for discussing patient and care partner preferences regarding those respiratory technologies should they be needed.
And those are really challenging, potentially emotionally fueled or emotional conversations. Even just talking to patients about how this disease may well progress. And I'm wondering, when you talk about introducing palliative care at the time of diagnosis, how that actually goes. What are some of the words that we should be using for those of us who don't practice this every day in clinic or have the experience that you do?
That's a really good question. And I think there's an age-old debate about actually changing the board name of hospice and palliative care because it can be so triggering for patients. We don't need to go down that line of discussion. But when I meet my patient and I think you probably have IPF, what I usually say is I always worry about my patients with IPF that they may feel a lot of symptoms and it may be a really hard disease to navigate throughout. And I wonder if it would be helpful for us to get you plugged into a special clinic to add this extra layer of support as you're navigating through your course with IPF. I actually don't usually use the term palliative care, to be perfectly honest, just once again, because it tends to be triggering and everything. And I found that just sharing in my worries about what the patient and their care partner may be experiencing down the line can be really helpful in having them remain open to a palliative care intervention or referral.
That's great. My mission, of course, is to try and achieve the goals of the patient and their caregiver loved one. And I want to keep the patient and the caregiver living as well as possible for as long as possible, whatever that means to the patient in terms of how they define well and define quality of life. But you're right, it can be so triggering. And as you mentioned, maybe we don't even use the term palliative care. We use wraparound care or cloak and remind patients that we're going to do everything we can to minimize your symptoms so that you're continuing to live well. That's all this is about. You've started a really fantastic clinic at Hopkins. Can you share with us what your clinic looks like and how you actually started your breathlessness clinic?
Thank you so much for asking. I was so lucky to have such administrative support from our pulmonary division in terms of this brainchild of mine that started during my pulmonary fellowship, and I really honed in on during my palliative care fellowship. And then when I joined faculty, I was really fortunate to be given all of the tools I needed to start this clinic. I actually intentionally named it the Breathlessness Clinic, once again, without palliative care in the name, just because it felt like a less threatening name for the clinic. We started it back in October of last year. And initially, we wanted to make sure that we were able to accommodate all of our ILD patients that, would benefit from this kind of support service, and have subsequently actually been able to expand to all patients with advanced lung disease. When I started the clinic, I knew that it would never be successful without a full interdisciplinary team. So I'm so lucky. We have a wonderful nurse practitioner who actually has a long background in oncology, ICU bedside nursing, which I think helps so much with her ability to think about patient management in such a different light than I'm able to. We have a few different registered nurses that also bring in different perspective that helps us as an interdisciplinary team think through the ways that we can best help our patients and their care partners navigate the disease course. We have a phenomenal social worker who actually has a nice background in talk therapy. She can't do it all the time, but she does schedule specific visits with our patients to just do a little bit of supportive counseling. She also worked in hospice, so she has that lens to kind of look through things in. And then we have a palliative care trained pharmacist who is my go-to person if we're just having someone with refractory cough and I can't think of any other interventions that might be helpful. And then one of the team members that I really wanted to make sure we had is a chaplain. And she has been able to reach our patients in a way that none of our other team members are able to do. And so I've been so lucky to have all of these different people with these different abilities to connect with and help our patients. And that's just been really beautiful. I actually intentionally separated the Breathlessness Clinic from our other ILD clinic, with the reason being I really wanted, to the best of my ability, put on a totally separate hat to really, really focus on the patient and their family and how they're doing and what we can do to help them throughout the course of their illness. That has been really helpful from both the patient perspective and the provider perspective, because within the constraints of a pulmonary visit, I wish we could address everything I want to address, and we can't. And so in accepting that and saying, hey, I hear you're really struggling right now. Let me get you scheduled in Breathlessness clinic. Let's talk through that when we really have the time and dedicated space to do that in the way that your emotions and your experience deserves. That part has been really well received by patients, care partners, and certainly by our whole provider staff. The other thing I'll add is logistically, the way that I structured the clinic is to make sure that I always default on my schedule to have 2 urgent visits, the first and last visit of the day. The reason I wanted to do that is because inevitably, there's always a patient or 2 that I see in ILD clinic and they are just really struggling. And I don't want them to wait 3 months to get on my Breathlessness clinic template. And so that's been a really nice way of allowing me to triage who really urgently needs to be seen and then having the ability to get them in quickly.
What a fantastic model of multidisciplinary and comprehensive care. At my center, I have a nurse practitioner who is trained in palliative care, who has started her own clinic. I don't think she's labeled it Breathlessness Clinic, but where does an institution that may not have access to a chaplain and all the wonderful resources of a social work and nurse, where do we begin?
I love that question. And I have been getting the question kind of with increasing frequency. And here's what I'll say. Just the fact that you are valuing such an intervention and are asking about it means this is something you absolutely can do at your institution. I actually don't think that you need formal training in hospice or palliative care necessarily to do this and to do this really well. What I would recommend for any center that wants to start something like this is just to start it and then let things evolve naturally. When I started Breathlessness Clinic, I had no clinical funding for any members of my interdisciplinary team. And it was with time and advocacy that I was able to progressively pull in more members of the team. And so I certainly encourage any center to try this, to start it. And then things will evolve over time to meet the needs of your patients and their families.
You and I have had discussions offline about how we integrate a palliative approach to care of patients with IPF and other fibrosing interstitial lung disease. Sometimes I don't recall, as I should, that a palliative approach to care, much of it, I feel like I'm already doing, and many, many docs who take care of patients with fibrosing interstitial lung disease are already doing. Pulmonary rehabilitation has been shown time and again in numerous studies to improve symptoms and to improve quality of life. Supplemental oxygen has data to support its use. Patients, even though there are burdens associated with dealing with supplemental oxygen and wrangling equipment, it certainly allows patients to be more active than they otherwise would be. So just by paying attention to supplemental oxygen needs and remembering that pulmonary rehabilitation is not only for emphysema, we could already provide a couple of things, at least, to our patients with IPF that fall under that palliative care umbrella. What are some other things that fall under that umbrella that we should be paying attention to?
That's a really good question. Certainly, symptom-directed treatment, not necessarily more global disease-directed treatments. So for instance, we know most of our patients with IPF suffer from a cough. Now, putting aside discussion of antifibrotics, whatever else we want to do for their management, I think it's really important to also dedicate thought and time towards that specific symptom and then talk about potential pharmacologic strategies for which I'm a huge fan of gabapentin. I think it really does work miracles on that somewhat neurogenic type cough that we can get with IPF. Similarly, I think the other symptoms that we know many of our patients struggle with, i.e. anxiety and depression, many of our patients actually do very well with SSRIs. And so I think as their pulmonologist saying, hey, let's think about some other medications that may make you feel better, even if it's not necessarily specific disease-directed therapy.
Do you objectively measure dyspnea and or cough and or fatigue in your clinic? Are patients filling out scales or surveys or questionnaires?
Yes. I have 7 PROs, and in an ideal situation, I have them complete the questionnaires prior to each clinic visit. That can be really challenging, and so it doesn't always happen. But ideally, having that objective level of data is really helpful for me as we're thinking about drug titrations.
So you might look at results of those PROs, patient-reported outcomes for the listeners, from visit to visit, and then at least be reminded that we need to address this change or, in fact, change therapy based on a change in the responses to the PROs.
Yes, exactly.
What doses of gabapentin have you found to be beneficial?
So this is a really important question because in clinical trials, we need to get up to 900 BID to really have benefit on cough. I have this dot phrase that I use with all of my patients when I start gabapentin. And the gist of it is that we always start low and then we gradually build up because of concern for side effects. However, I really, really don't like my patients to come off of it once we start until they reach that threshold of 900 BID. And then if we get there and I really feel like we're therapeutic and we're not seeing any benefit to cough, then I think it's fine to discontinue the medication. But I've actually had a few patients that have done beautifully on 900 TID without side effects. And it took us several months to build up to that dose. But it really is important that we stick with it and we don't give up on the starting dose of 100 QHS because it's not a drug that's going to work immediately on cough. And so once again, I think a lot of upfront education that, hey, this isn't going to help you immediately, but I believe that we have a good chance that it will help you down the line.
Great. One more question. When we talk about breathlessness and specifically air hunger that a lot of our patients will experience while exerting despite very high flows of supplemental oxygen, can you share with us a bit about the role of opioids with respect to treating breathlessness and air hunger?
So I am a huge proponent of opioids. I think it is the one medication that we know can specifically target the sensation of breathlessness. And so there's a lot of erroneous concern about respiratory depression. Remember that we have neurologic depression prior to respiratory depression. So we're never going to let our patients get to that place. As long as our patients have normal liver and kidney function, I actually really like starting with Roxanol, which is the very concentrated sublingual morphine solution. The reason being it works very quickly. And so it is really helpful in those moments where patients just hit this breathlessness to anxiety spiral. I start actually at a very low dose, usually 5 milligrams of the Roxanol, and then we'll slowly up titrate to 7.5 or 10 milligrams. I usually start them every 4 hours and then decrease down to every 3 hours as long as they're not having side effects from it. Opioids themselves oftentimes will cause a little bit of GI upset initially. That absolutely gets better over time. The one side effect we always want to caution our patients about that does not improve over time is constipation. So even when I start really low dose, I always say, let's just get you on some Senna. Let's just make sure we're being proactive about things. Now, in patients that may have some renal dysfunction or maybe on dialysis, sublingual oxycodone works really well. We have some nice data within the COPD world that if we're needing a lot of PRN opioid, there is actually a nice role for something longer acting. I would say I do that infrequently, but certainly I think there's a patient population that really benefits from that.
Fantastic. So we've covered a lot of ground here today, Anna. Give us one final takeaway that those of us who are practitioners in the audience can take away from your expertise in this discussion.
What I would say is that I find the easiest way to connect with patients is to normalize what they might be feeling and then try to offer other supportive services. So an example of this is within the pulmonary world, a lot of us feel uncomfortable talking about mood and where we are with mental health. And so what I always say is the majority of our patients with IPF are experiencing depression and or anxiety. Is this something that you might be feeling? Is this something that might be helpful for either us to talk about or for me to refer you to another provider to talk about? And I think that within the pulmonary world, we don't always know or are trained exactly how to address these very common symptoms, but it really permeates all of the care of these patients and the way that they're able to participate in therapies like pulmonary rehab, take their medications, come to appointments, use their supplemental oxygen. And so what I would encourage everyone listening to this podcast to do is think about the most common symptoms that our patients with IPF experience and potentially add that into your regular clinic visits just to screen for those symptoms, even if you don't talk about treatment, and just normalize it so the patient doesn't feel like they're different because they're feeling anxious or depressed.
Wonderfully said. That is fantastic. Thank you so much for joining us today, Anna, and bringing up that imagery of the cloak in the palliative care of patients with IPF. So wonderful to have you here as a guest today. Thank you so much.
Thank you so much for having me.
We've had the real pleasure of talking to Dr. Gersten about integrating palliative care into the management of our patients with idiopathic pulmonary fibrosis. She reminded us that palliative care is directed at improving symptoms and quality of life that are really impaired and prominent in our patients with IPF. She has started a wonderful breathlessness clinic at Hopkins, which is really a model that all of us should strive to achieve. She also reminded us, though, that if we can't get to that place where we have this comprehensive multidisciplinary clinic available to us, talking to patients and reminding them that if symptoms worsen, we have resources that can certainly help. Thank you very much for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on idiopathic pulmonary fibrosis. This is Dr. Jeff Swigris for the Medscape In Discussion podcast.
Thanks for listening to Season 2 of Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.